Hello, everyone, and welcome to today's webinar, When Class 2 Meets Crossbite, a SoftSmile Case Walkthrough. My name is Nina. I'm the Professional Relations Manager here at SoftSmile, and I'll be facilitating today's session. We're so pleased to have Dr. Luca Galli, Orthodontist and Clinical Consultant at SoftSmile, with us today. Dr. Galli will walk us through a real patient case and demonstrate how SoftSmile aligners and powerful vision tools can provide better control and treatment planning and ultimately deliver predictable outcomes in more complex scenarios. Before we begin, I do want to let you know that we will have a Q&A at the end of the session, so please utilize the question and answer tool at the bottom panel of your screen. And with that, I'll go ahead and turn it over to Dr. Galli.
Thank you, Nina. Thank you, Nina, for the introduction. And hello, everyone. I really appreciate you taking the time to join us today. As Nina mentioned, I will be presenting a comprehensive walkthrough of a complex case. I'll be taking you through my entire workflow from the initial clinical diagnosis all the way to sending the final setup for production within SoftSmile and Vision ecosystem. So let's get started. Here's our agenda for the session. We'll begin by establishing the diagnosis baseline, outline our specific treatment goals, and finally detail the treatment plan and mechanics required to achieve them. So let's dive into the diagnosis records. Our patient is a 16-year-old male, and he and his family present with a chief complaint of an unbalanced bite and dental protrusion. So in this initial approach, as can be seen in the external photos, the patient presents a brachyfacial hypodivergent phenotype with a convex profile. Looking at the occlusal views, the maxillary arch is relatively well aligned, though we do know the presence of anterior diastemas. The mandibular arch, however, presents significant challenges. This is severe rotations on the premolars, mild crowding in the anterior segment, and noticeable posterior decompensation on the right side, involving both molars and premolars as a direct result of the crossbite. So intraorally, our primary focus is the severe right side discrepancy. The cusp of the upper canine falls directly on the center of the lower canine with a similar relationship on the premolars. The molar relationship is also a half class 2, complicated by a posterior crossbite where the upper mesial cusp falls into the lower central fossa, which is inverted. So we're dealing with both as sagittal and transfer components on the same side. Additionally, we note that the mandibular midline is mildly deviated to the right. On the panel, what stands out is the overall excellent dental health. So no restoration and a clean general picture. So well done to him and his family. However, we know the presence of impact third molars in all 4 quadrants. So to facilitate our planned distalization mechanics, these were extracted prior to the treatment. Now let's see the skeletal diagnosis. This cephalometry was generated inside the platform. This is one of our latest updates. I won't bore you with loads of values, but we found a skeletal class 2 tendency and bimaxillary protrusive positioning. When we look at the vertical pattern, we see that it's consistent with a hypodivergent brachyfacial patient, which clinically matches the deep bite tendency that we will manage through staging and finishing. So overall, mild skeletal class 2 tendency, brachyfacial growth pattern, and bimaxillary protrusion. Now that we've framed the diagnosis, let's define the treatment objectives and then translate it into a practical mechanics-based plan. So our goals are divided into 3 dimensions. So first, sagittally, reduce the overjet and also close the diastemas. And of course, correct the right side class 2 relationship. Second, transversely, resolve the posterior crossbite and expand the right side. And third, vertically, we need to strictly control the deep bite tendency, improving the curve of SPI. So overall, establish a harmonious aesthetic and functional occlusion. To achieve these goals, our treatment plan consists of upper right posterior distalization, crossbite correction, sagittal control, and active leveling and bite refinement, specifically managing, as I said, the curve of SPI, and finally, detailing and finishing. Now, how will we execute this mechanically? For the posterior distalization, we'll implement a half-step protocol. The crossbite will be managed using cross elastics, sagittally early class 2 elastics to provide the necessary anchorage during distalization. And to control anterior torque, we are incorporating translate blocks. Finally, to manage the deep bite tendency, we'll use anterior bite ramps toward the end of the treatment. So before looking at the biomechanics, I want to briefly show you the baseline workflow within the Vision portal. Here you can see the platform interface. We have access to all patient records, photos, scans, RX, CBCT, and direct communication with the orthodontist who will handle the design on the right. The most powerful aspect here is the clinical control we have during case submission. I can explicitly state, for instance, that the third molars were extracted, specifying my target class 1 molar and canine goals, midline centering, and precise elastic or expansion protocols, where and when I want auxiliaries, and many other things. A highly useful feature also is the spacing tool, which allow us to measure and communicate small interproximal diastemas that intraoral scanners sometimes just close up. Once the setup is ready, I can review the version history and either jump straight into edit mode to fine-tune the final alignment myself, or open it in Vision Viewer for a cleaner and polished presentation. So here you can see the Vision Viewer, where you get a rendered view of the entire treatment plan, including the movement table and several review features. From here, you can approve the plan as it is or request modifications if needed. On the other hand, you can open the Vision Editor, either directly in the web browser or in the desktop app. And this is where you have the full power of Vision, everything from staging panel to auxiliaries, articulation tools, and more. Here you can directly refine the final alignment yourself and approve the case, or still ask the orthodontic design team to implement the changes. Now that you've seen the portal workflow, let's move into how I actually review a setup clinically. The first thing I check in an aligner setup is the segmentation. It's some basic, but it's absolutely critical. I'm looking for scan artifacts, clean tooth boundaries, and most importantly, interproximal contacts that look anatomical and not artificially flattened or block out. Because if segmentation is off, everything downstream gets affected. Fit, collision detection, space and IPR decisions, and the predictability of movement, especially when we have crowding or big rotations. So before I judge the mechanics in the treatment plan, I want to be sure that model itself is reliable. And as you can see here, the tooth morphology says natural, inaccurate, uh, no matter which step we're on. So the anatomy remains consistent as the setup progresses. There's even a recent independent benchmark study comparing vision segmentation with other leading systems, and it report superior performance. And honestly, that lines up with what we see clinically in terms of fit and space management. So the clinical takeaway here is that preserving the natural morphology of the tooth provides a real-world collision detection, which is vital when resolving severe crowding or planning IPR. So next, we address the staging. Given the high biomechanical demand on this case, we classify movements as either standalone or combined. So standalone movements prioritize absolute anchorage, separating antagonistic forces to ensure full clinical expression. And combined movements focus on efficiency. So we group synergistic and complementary movements to shorten the treatment plan without sacrificing predictability. Now, let's take a look at the staging for this case. First, from the frontal view, you'll see we start with a control expansion on the right side while keeping the upper anterior segment locked. The idea is to build stability first so we don't lose anchorage when the bigger movements begin. Then switching to the right sagittal view, we move into upper posterior distalization using a half-step protocol that keeps the movements more predictable and reduce the risk of pushing too much too fast. And in the occlusal view, you'll notice we're expanding and distalizing at the same time. In this case, we choose to combine them because the upper first molar is slightly rotated, and this gives us a much better surface to drive the distalization without unnecessarily prolonging the treatment plan. On the lower arch, we protrude and intrude the lower incisors first, and only after that, we do address the torque. Basically, a mild round-tripping approach to keep things controlled and avoid unwanted interferences early on. Here we're focusing on the lower arch because this is where the curve of speed strategy becomes really clear. First, we protrude and intrude the lower incisors to start opening the bite and create space for the sagittal correction. And then later, we bring them back while refining torque control so we don't finish with flared incisors. Once elastics comes in, we also use them to support the posterior extrusion, which helps level the curve of speed and stabilize the vertical dimension. Now I want to show you here is how much control we have when we want to keep movements independent instead of letting everything happen at once. So for example, let's take the lower incisors torque. If I don't want that torque to kick in too early, while I'm still focused on intrusion, leveling, and space management, I can go directly to the movement timeline, right-click on that tooth timeline, and choose extract movement. That basically removes it from the current phase and lets me push that torque correction toward the end, where it becomes a clean and finishing step. And once I do that, I can take the key staging points, the goals or milestones, and simply drag them to the point where I want retraction or torque correction to begin. So I'm organizing the treatment plan in a more biomechanically sensible order. First, the movement that build stability and clearance, and then the finishing movement that would otherwise compete. Sorry. And at the end, what I'm showing is how we keep tight control of that goal while focusing on space management. As we shift movements in the timeline, we can track how space is created and used at each stage and adjust the sequence accordingly while keeping collisions under control. Now staying on the same idea of control, you can see how simple is for the doctor to make adjustments directly without sending the case back and forth. Here I'm doing a quick modification, like adjusting the rotation of tooth 25. And now I'm adding overcorrection, basically planning a virtual C chain to manage the anterior contacts. The goal is to guide how those contacts finish so we don't end up in spaces that remain open. These are kind of the small changes that we can save a full extra iteration when the rest of the setup is already on track. So the key point is in this here is that you can make these fine alignment tweaks quickly, keep control of contact finishing and approve the plan or request modification if you want, without losing time in multiple back and forth cycles. So in other words, this level of control translates directly to predictability, efficiency, and speed. In my opinion, being able to handle the final detailing myself removes a lot of unnecessary workflow bottlenecks. From my perspective, in about 90% of the cases, maybe I'll find a few small details I want to tweak, and maybe a minor rotation or a contact finishing or a bit of torque. But sending the case from one more iteration just for those tiny details often creates more work and more delay than simply adjusting it myself in a very quick, in a straightforward way. Now I'm moving on the next clinical lever, which is attachments. In a case like this, where we're asking for posterior distalization, vertical changes, and large rotations, attachments are not just helpers. They are a big part of the biomechanics and anchorage strategy. And this is where the idea of phantom forces becomes important. With aligners, you can unintentionally create force systems you didn't plan for, simply from how the plastic contacts the teeth and how attachments are shaped and positioned. So instead of placing attachments purely by intuition, the goal is to understand what the aligner is actually trying to do at each stage, and then design the attachment to support the movement we want, and avoid side effects that we don't want, of course. And here's where, the feature phantom becomes really, really important. The key shift is moving from intuition to a physics-driven visualization of what the aligner is actually delivering. And there are three practical rules I keep in mind for this. So first, orientation. You want the active edge of the attachment aligned to its essentially perpendicular to the main vector direction you're trying to express. Second, you place the attachment where the system shows the highest density of the longest arrows. That's where you're getting the most meaningful force application. And third, avoiding dead zones. If you see, for example, circular vectors or swirls, placing an attachment right on the center usually doesn't help because the net effect there can be inefficient. Look at this severely rotated premolar. As you can see, the software displays the force vector for each aligner step. So we're not just looking at the attachment shape, we're looking at where the aligner is actually pushing, in which direction, and with what relative intensity. The longer and denser arrows show where the system is delivering the main load. In a rotation like this, what we really need is an effective couple. Two opposite forces generate the right moment to express rotation instead of just tipping the crown. So with small adjustments, you will see how we can reposition the attachment slightly so it sits in the area where the vectors are strongest and more consistent. Um, and right away, you can see how the vector field changes across the steps. While doing that, I'm also checking, of course, the occlusion. Here we use the occlusal map to make sure we're not creating an interference with antagonistic. So we're balancing two things at the same time. The force system we need for the movement and the occlusal clearance we need for control and function. So the takeaway from this, I think, is pretty clear. This approach reduced clinical guesswork. When the attachment placement is guided by the force vectors, you're much more likely to end up with a force system that match what you're trying to express. And clinically, that translates into better tracking and fewer refinements, especially in teeth with high demand movements like rotation or vertical control, as in this case. All right, so the next lever is by control. In aligner cases, especially when you're combining sagittal correction with transverse mechanics, occlusion can evolve in ways that are uh, easy to underestimate. So I'm not only planning tooth movement or alignment only, I'm also planning how the patient is going to finish functionally. And this becomes even more important toward the end of the treatment because that's where small occlusal interferences can create instability or trigger unnecessary refinements. So here's how we assess and manage that inside vision. First, we use the occlusal heat map to visualize distribution. Here you can see that the posterior contacts are present, but the curve of P is still very pronounced, which is exactly the kind of thing you want to monitor before finishing. Then we move into the function using the virtual articulator. We check the lateral excursions, first to the right and then to the left. On the right side, you can see that more cannon guided pattern. On the left side, you see more group function involving the cannon and first premolar. And if we want to refine the simulation, we can adjust articulator parameters like bending angle, for example, to better, of course, evaluate the functional contacts and potential interferences. And in cases where we have a CBCT, we can take this a step further. We can visualize the mandibular movement with a more anatomical reference. So we're not only looking at the crowns and contacts, but also at the joint contacts and importantly, the roots. That gives more control when movements are close to the biological limits because you can better appreciate the relationship to the buccal and lingual corticals throughout the treatment. So the takeaway here is the earlier we assess occlusion and function in the plan, the fewer surprises we get later. If we want I mean, if we wait until mid-treatment, of course, or worse, until the end, occlusal issues can become the reason for repeated refinements. So planning it upfront improves predictability and finishing stability. And from a biological standpoint, it supports safer outcomes. It helps reduce the risk of occlusal trauma, improves functional stability, and gives us more confidence in the result, including, of course, from a TMJ perspective. So next, tracking loss is one of the most common issues we face during aligner treatment. And even with well-designed plan, uh, it can happen for many reasons, like biology, attachments, performance, and of course, patient's compliance. So the key point is that when an aligner stops tracking, it's not just a small detail. It changed the starting point for every single movement that comes after. So we want a way to detect problems early and respond before the case drifts for weeks. That's why during the treatment, I'm consistently checking fit clinically. And when something feels off, sorry, I want an objective way to compare the patient, like how the patient is versus where the aligner expects them to be. So here's where matching comes in. The idea is simple. Instead of guessing whether the tray is tracking, we can compare the current situation to the planned stage. And if a patient is supposed to be on, I don't know, let's say liner 20, we can take new upper and lower scans and match them against that stage to see how close we are. Um, this gives us a much more objective way to decide what to do next, whether we can keep going, need to hold the same aligner longer, I don't know, use pliers, or whether it's time to intervene and update the plan. So now I'll show you how matching works in practice. Here I'm submitting a matching request. I upload updated upper and lower scans and select the aligner stage that the patient is currently on. That creates a quick checkpoint so we can compare the real situation to the plan setup for that stage. So this is what you get behind the scenes. Let's say that the patient is currently on aligner 12. We upload a new scan, and the software overlays the actual dentition against the planned stage for that aligner. So you can immediately see any discrepancy, not just visually, but also computed. And what I like here is the movement level breakdown. The system highlights which teeth are off track and which specific movement are not being expressed. So you're not guessing whether it's a rotation issue or torque issue or whatever. So from there, if we decide it's time to intervene, we can trigger the bottom refine treatment, and the plan is recalculated starting from the current scan. So the rest of the treatment plan is built on the patient's real position, not on an assumption that they are still tracking perfectly. The clinical value here is massive, in my opinion, because we can intervene early. I mean, we don't have to wait 2 months of watching teeth fail to move. This makes everything easier to predict how things will go during treatment and reduced the need for endless refinements. Well, now we're moving on the results by superimposing the initial and final positions. First, you can see the transfer correction, especially in the right side, where we achieve the expansion needed to resolve the posterior crossbite. Then in the sagittal views, you can appreciate how the plan combines biomechanics, like cross elastics, class 2, and translate blocks. This is to support distalization and sagittal control while keeping the case stable. And finally, looking at the anterior view, you can see how the midlines are matched at the end of the treatment, which contributes to a more balanced and static outcome. Now, a few things that I really watch during the treatment, because this is where cases like this can start to drift if we're not on top of it. So first, during distalization and expansion, I always check we're not getting only crown tipping, especially during distalization. I want root control too. That's why in some cases we plan a bit of tip back overcorrection, just to make sure we actually express the movement clinically. Second, vertically, I want to avoid the bi-block effect. So I don't rush over the anterior retraction. I'll usually create clearance first, mainly by intruding the lower incisors. And only then I go after the overjet, because otherwise the bite can lock and everything becomes harder. So third, I keep an eye on the curve of speed. I want to see that leveling is happening the way we stage it and not just on paper. And lastly, because aligners are doing a lot of the work here, I'm very proactive with elastic wear. Of course, I explain this to the patient, and if compliance drops, sagittal correction and crossbite correction looks predictability very, very quickly. So if I had to summarize what makes this case predictable, it comes down to three things. So first, staging control, stabilization, and transverse correction only work well if the sequencing is clean and anchorage is protected. Second, attachments. In a complex case like this, attachments are doing a lot. They're supporting anchorage, improving grip for rotation, and helping us express vertical components without losing control. And third, functional stability. I'm always thinking about the endpoint. This is stable occlusal contacts and stable interproximal contacts. Tight enough for good finishing, but not so tight that they create movements lock. And I think that that is what gives me a result that holds, and not just a result that looks good on the setup. Okay, so that's it from my side. Thanks again for having me, and thank you all for joining and staying to the end. I hope this walkthrough was useful, not just the case itself, but also the workflow and the clinical decision points along the way. So now I'm happy to take your questions. I'll pass it over to you, Nina.
Thanks, Dr. Galli. It's very useful to see how you approached that case and really just showcasing how vision has allowed you to deliver the best care, right, for your patient. So thank you so much. We do have some questions here, or we do have one. I'm going to see if this will post, but The first question says, "Hi, Dr. Galli. What mismatch threshold do you usually set for matching? For example, distance in millimeters is 0.1 and angle in degrees is 1.5. Do you use these values or something different? And why do you prefer that threshold?"
Well, I usually use 1 degree for rotation and for translation 0.5. But again, depending on the case, when I use matching, most of the time I use it for like to check the discrepancy. So if we have discrepancy, but it's not that big, I can go back one or two trays, use pliers, and verify after 1 month how how that did work, and like without like updating the treatment plan, right?
Okay, great. And then the next question says, "How do you determine which red values in the matching are the most critical? Is there a specific threshold or distance in millimeters that you consider clinically significant?"
Well, as I mentioned before, you can set your own threshold. I think that's something great in Vision, that everything can be like customized for each doctor. So you can set your own values, and of course, not only guide yourself with the numbers in the movements table or the matching table, but also verifying visually how the current scan has a mismatch with that stage, right?
Okay, great. And then we have a another question here. Actually, it's I think several questions, so I'll kind of break it up for you, Dr. Galli. So it says that, "Thank you for the great presentation. I have a few questions regarding the biomechanics of the case. So, first and foremost, did you incorporate CBCT analysis when planning the case, specifically to evaluate the relationship between the roots and the alveolar bone, and to check for possible fenestrations or dehiscence during the planned movements?"
Yeah, of course, that's the ideal scenario. That's why I show the slide with the CBCT, because for these cases, the ideal scenario again is to upload the CBCT. In this particular case, the patient doesn't live in the city. That's why I just use the cephalometry, and I didn't request for a CBCT.
Okay, great. And then the second part to this question, regarding the bite ramps, do you design them only integrated into the aligners, or do you also sometimes also place composite bite ramps directly on the teeth?
Yeah, no, only in the aligner. I don't use them as like biturbos, like in braces. The aligner is enough to block the anterior segment. Yeah.
Okay, great. And then we have another question. So, regarding the tooth with the complex movements, any suggestions on attachments that you should use on that one? Also, let's see, there's a lot of questions about bite ramps here, but are you using the basic bite ramp provided by Vision, or are you customizing your bite ramp?
I use the default BIRAMs provided by Vision, but also you can upload your own STL files if you want to use your BIRAMs. And the other question was about the movements. Well, it will definitely depend. It depends on which movement we need to achieve in which tooth is it. Of course, we have our own protocols for these for different scenarios, but also we can incorporate doctors' protocols. But for example, the scenario that I showed about the highly rotated premolars, for those scenarios, I like to place bevel attachments on the buccal surface, like big attachments, not the tiny ones, and vertical, maybe smaller attachments on the lingual surface to generate that couple movement. And if I see that that is not enough for that case, and during the treatment I see a lack of tracking, you can also incorporate elastics to rotate them.
Great. And then this next question asks, well, it says, thank you for the great lecture. In your experience, which tooth movements tend to track the most predictably with aligners and usually don't require refinements?
Well, definitely translation, right? Expansion is highly predictable with aligners, and proclination too. And again, depends on the teeth, because I can say rotations are hard in canines and premolars, but not in an upper central. Yeah.
Okay, and then this next question, if a refinement is needed, how can it be overlaid and reset backwards using the final result of the first setup? Is it possible?
Yeah, it is possible. Probably Edil could respond this question in a wider way, but it's possible to just in the same treatment plan panel in the portal, you can upload refinement and follow the first treatment plan, the first outcome, as we do in the matching tool.
Okay, yeah. Adil can jump in whenever he's Adil. If you're here, please feel free to jump in. But in the meantime, we can go on to another question. I'm going to post it in the questions tab, actually, Lucas, so you can visualize it. It's a bit of a long question here. So give me just 1 second to post it here. Okay, let me just read out the first part and then I'll break it up again. So I noticed that in the case, there were 2 attachment placed on the same tooth. In situations where a tooth appears to move beyond the expected limits within the alveolar bone, potentially approaching the cortical plate or losing optimal periodontal support, how do you manage that clinically? And do you pause the treatment to reassess with any imaging?
Okay.
Do you apply biomechanics or? Yeah.
Yeah, like if during the treatment I have a fenestration or a recession, right? Well, in that case, of course, we stop the treatment at that time. We could request a CBCT, and there, using the matching tool, you can match the current state for the patient and modify the treatment plan according to it, right? So usually when you have fenestration, you take the tooth back. Usually it's related with torque. So yeah.
Okay, great. Any other questions from the audience that we could help address? I know there may have been a question that we were waiting for Adil to answer, but in any case, if he's not free, you can always send that to us and then we can get you an answer on that. I see someone's typing, so yes. I think Adil may be jumping on.
Can you hear me?
Hi, Adil. How are you?
All is well.
Thanks for joining.
Sorry, guys, for the background noise. Hopefully, I will try to just be quick with this answer.
No worries.
The matching feature allows us to perform refinement. If I understood the question correctly, I mean, your final goal is always intact. You always have it from your original treatment plan. So if, let's say, by the end of the treatment, you have not achieved your desired result and you uploaded new scans, you perform the matching, you can generate additional trays. Your final result, your final position of the teeth, desired position of the teeth is still there. So you can perform matching, actualize the positions of the teeth at the at the current point, and then generate additional trays as a result of that matching. So if I understood the question correctly, again, the final position is always there. It's always stored. You can correct it if needed, but you can otherwise basically get to that position with additional trays if needed. Hopefully that answers the question.
All right, thanks, Adil. I think we have one final question here that someone is typing. Let's see here. No question. Okay. We have a remark, Dr. Galli. Thank you for the excellent webinar. They said, really appreciate the opportunity to hear your experience and insights.
Thanks to you, Doctor.
Yeah. Amazing. Thanks, Dr. Luca. Thank you so much. If anybody has any other questions, Luca, if you don't mind going to the next slide. We do have a QR code here. If you are new to SoftSmile, please feel free. If you want to know more information, you're more than welcome to book a meeting with our team using that QR code. And then also, I think if anybody from our support team can chime in the chat, we may have like a support email address for anybody that didn't get to ask a question or maybe still thinking about a question in regards to anything that Dr. Luca covered today, but we'll be more than happy to address those for you. So if we don't have any other questions, we can go ahead and close out today's session. Thank you so much for everybody that joined us. And of course, Dr. Luca Galli, thank you for your insights today. We really appreciate it.
Thanks to you and thanks everyone.
All right, thank you. Until the next time.
See you next.